Okay, so I'm going to give a brief status update of screening for melanoma, including some of those issues John was just alluding to a moment ago. So first of all, I have no financial conflicts with any commercial entities related to screening for melanoma, although I am a dermatologist. Many of my patients see me because either they have or have had melanoma or they're afraid of getting melanoma. And so if we were really to get rid of this problem, I'd have to find another line of work. But now that they approve Botox for crow's feet, you know, maybe. But anyway, screening for melanoma. So huge potential to save lives, I think, within a decade, as opposed to primary prevention where it's going to take many decades to see the effects. Secondary prevention with screening, we can see substantial reduction in deaths in a fairly short period of years. Right now, I imagine these numbers have already been recited as close to 10,000 melanoma deaths per year in the U.S. We really need to cut that in half. But in order to do that, of course, the essence of screening for melanoma remains not a blood test, not an invasive procedure, but in fact looking at the skin. Whether it's the patient looking at their own skin or a family member looking at the patient's skin, or a physician such as a primary care doc or some specialist looking at the skin. Someone has to look at the skin. And the central irony of our melanoma problem that's killing so many people is that people are not looking at the skin. So surveys that have been done of full body skin examinations by primary care docs, by specialists, show that most don't do a full body skin exam. And indeed, there are even a lot of dermatologists who you'd think would be the ones who always do it. I mean, some always do it, but others don't. And in terms of people examining their own skin with a thorough skin self-examination on a monthly basis, which is our recommendation, most patients don't do it. So most patients don't have their docs looking at their skin. Most patients don't look at their own skin. So you can have melanoma growing there right on the surface, and no one sees it until it's too late. And this is the sort of central irony of the problem we deal with. And there's some documentation there and references. So, so John alluded to the U.S. Preventive Services Task Force. I won't dwell on it at length. They concluded, contrary to Consumer Reports recitation, what the U.S. Preventive Services Task Force concluded is that there's insufficient evidence to recommend for or against routine screening for skin cancer using a full-body skin exam. Consumer Reports translated that into the evidence says don't go for a skin exam, and so that's something you should avoid. That's not what the U.S. Preventive Services Task Force said. That's just what Consumer Reports said, a misreading of or misrepresentation of the U.S. Preventive Services Task Force. So the U.S. Preventive Services Task Force said this. I mean, we don't have randomized trials. They're looking for that type of high-level evidence, and we'll talk about the hierarchy of evidence in just a moment. But it's interesting, in their most recent recitation, they've said this multiple times as when they've looked at this evidence more than once. Most recently, in 2009, the Annals of Internal Medicine, they said this, but after saying this, well, we don't have the high-level evidence, there's insufficient evidence to recommend for or against, what did they say in the very next sentence? Look at that issue. The very next sentence, this is what they said. Clinicians should remain alert for skin lesions with malignant features. So I know the screening literature reasonably well. I can guarantee you there are no randomized trials comparing drowsy to alert clinicians. So I don't know where they came up with this, but that's what they say. So obviously they're struggling with certain issues about when they need to use evidence and when they just need to use clinical judgment, and when and how they deal with that whole gray area where people are always looking at their skin, sort of, and we like to recommend that they do it methodically. And so, you know, and how do you evaluate the evidence on that? So, but that's the current status. So just to remind everyone, which you probably don't need reminder, but just to go through it so we're all on the same page, the hierarchy of evidence, and this is what the Preventive Services Task Force and other authoritative groups adhere to. And of course, top on the hierarchy of evidence, the most potent types of studies, as I think most of you know, is systematic reviews of randomized trials, individual randomized trials. We don't have any of that for melanoma screening, just doesn't exist. We have some time series. So the next thing is multiple time series. That's what got cervical cancer accepted as a pap smears for cervical cancer prevention or early detection. And it was multiple time series that were published. And it wasn't randomized trials that convinced the world that that was worth doing. And so that's something we're starting to work on with melanoma. We have some time series. We'll talk about that in a minute. And then there's lesser evidence, or evidence of a lesser degree of rigor. It's still important evidence. It's still evidence that's useful in pushing you in one direction or another, but it doesn't reach the same height as these types of studies. And these are primarily the observational type of studies, the cohort studies, the case control studies, the ecologic studies. And in particular, relevant to melanoma screening is a series of case control studies which have had some very important conclusions that I'll go over with you. So they're important evidence, but they're not as strong as the other types. And this is sort of humbling, but I have to admit it in full disclosure, the next thing lower down on the hierarchy is expert opinion. So this is opinion of someone like myself, I like to think. I'm an expert, but I'm pretty low on the list. So, so it gives me a bit of humility, but on the other hand, I am encouraged because I'm not at the very bottom of the list. There are things lower than even my opinion. So if you go lower on the list, you have things like spam and so on. So anyway, a hierarchy of evidence, and of course there are more types of studies. One can flesh this out more, but that gives you the basic outline. So what evidence do we have for screening for melanoma? Well, the two key questions: does screening for melanoma save lives? And two, what evidence do we have that the benefits of screening are worth the harms that are associated with screening? And so we'll go over this in a bit more detail because this field has really been revolutionized over the past 5 years or so. And once we get good evidence on these two questions, it's critically important because it's not just an academic issue. Once we get good evidence, then that can be translated into motivation and determination of policies at health maintenance organizations, accountable care organizations, health systems, etc. And so these things can actually be implemented on a mass scale once we have the strength of evidence that will convince these sort of arbiters of the way healthcare is delivered that this is something that's worth doing for their entire populations that are covered. So, you may ask, don't we know that melanoma detected by screening is thinner and hence better prognosis? And of course the answer to that is yes. We know this. We've known this for a long period of time. But that's not good enough. And the reason why it's not good enough is because the people who are screened could be a selected group who are going to have a different type, could be biased in a number of ways. That screening may find slower growing lesions selectively. So when you do a screening, you pick up all the slow growing lesions, you don't pick up the fast growing lesions. and so you can treat the slow-growing lesions, but does that do you a lot of good? Screening may detect lesions earlier that are destined to become melanoma, but perhaps not early enough. Maybe the people die anyway. Now, if you detect it a year earlier and the people die a year later after detection, you may say, hey, they survived a year longer, that's great, but of course that's totally not great because it just means that you detected it a year earlier in the history and it doesn't mean that you saved any lives. And of course, with screening, you may detect lesions that never would have been fatal, that aren't true malignancies, but that were called melanoma. So we have to get a more rigorous level of scientific evidence. And so let me go through some of the key aspects of what we have. Skin self-examination. So I'm going to start with case control studies. I mentioned there's two ways of screening for melanoma. You have skin self-examination, which could be the patient, his or her family, or you can have a clinician doing the screening. So for skin self-examination, a key study was published many years ago by Berwick, and that was a case control study with 5-year follow-up of cases, and they found basically a 2/3 reduction in advanced or lethal melanoma associated with monthly skin self-examination. One case control study. But there's been other supportive evidence, perhaps somewhat weaker in terms of the level of rigor, but still nevertheless supportive, case studies, et cetera, and the references there. Clinician examination, this is probably the best study in the case control area. That was a study of clinician examination within 3 years, associated with actually an increase in very thin melanomas, but a progressive decrease in thicker melanomas, so that by the time you got to melanomas greater than 3 millimeters thick, there was a 40% decrease in the risk of those melanomas associated with just having had a clinician examination in the past 3 years. Now, this was done in Australia, in Queensland, which is melanoma capital of the world, highest rates. And so those clinicians tend to be more skilled, I think, than clinicians in places where melanoma is not as common. Nevertheless, they projected that this, just having a clinician examination every 3 years, could result in a drop in melanoma death of about 25%. And there's a supportive case study as well, lesser degree of rigor. And then we get into the time series, and here we have 2 time series so far to talk about. The first one was published 5 years ago from Lawrence Livermore. It was a time series about the experience of the employees of Lawrence Livermore National Laboratories. Lawrence Livermore National Laboratories does work with all sorts of radiation. They thought, oh my God, we've noticed a lot of melanomas. Maybe it's the radiation that these employees are getting at work that's giving them melanoma. We better study this and figure out what's going on. They did study it. It turned out there was no relation to radiation. In fact, the people who were mostly in an office working with computers and things like that were the people getting the highest risk of melanoma, as opposed to people actually working with the radioactive compounds. But what they found, what happened at Lawrence Livermore is, first there was an awareness of this melanoma risk, and then there was an actual formal screening program by a dermatologist of all the employees. And that's what we see here in this graph. And let's see if I can make this work. There we go. Oh, this is good. This is bright. Okay, so the in situ melanomas, when you go from the pre-awareness period to the period where there was awareness to the period where there was a formal screening program, they found more and more in situ melanomas. So a higher population-based risk in the employed population of in situ melanoma. And the thin invasive melanomas bounced around a bit, but when you look at the thicker melanomas, greater than 3/4 of a millimeter thick, those are the solid lines here, not the dashed lines. both of those went down as more awareness and screening happened in that population. And in the last period, they actually had no deaths from melanoma compared to an expectation of 3.4 deaths. So, and that was statistically significant. So it seems that that's at least one time series that suggests that screening for melanoma can save lives. And that was the first that was published. And then the one that Axel will be talking about in just a moment, so I won't go into it in any detail, but this is the state of Schleswig-Holstein, where there was a population-based screening, and it went from this pre-screening period where you have Schleswig-Holstein, which is this state right there. It's one of the federal states in Germany. You have that having a fairly high incidence before all this activity, and then after all this activity, it turns into a very pale color, while all the surrounding states to the north, south, east, and west had relatively little change. So, and in Schleswig-Holstein, the reduction was close to 50% over a decade. So, so he'll give you the details on that following this talk. It's the most important of the evidence we have so far, and it's the second time series now we have, and there will be more. There will be one with all of Germany. There will be one with Western Pennsylvania. So, so these are coming. And that may be the type of evidence that eventually convinces the accountable care organizations to say we should do this for all of our patients that we care for. So where do we go from here? Well, we have to establish the efficacy in saving lives. Randomized trials aren't going to happen, but as I was just mentioning, we have multiple time series either happened or on the way, and that may be the best we can do. And hopefully that will be convincing to the authoritative bodies who adjudicate these things. But we also need to focus on other effects of screening for melanoma. There will be overdiagnosis. There has been overdiagnosis whenever we've done screening, and we suspect melanoma is going to be the same. And that has consequences. That means there's a risk of more procedures, more referrals with associated costs, et cetera. So it's not, even though a skin exam doesn't have direct morbidity, these indirect consequences are something that we need to measure and take into account. Not as consequential as, say, lung cancer, where a false positive diagnosis results in an unnecessary major thoracic surgery, but nevertheless has some consequence. We need to measure it to convince the powers that be that this screening is worthwhile, if indeed it is. We must show the benefits are worth the harms. And this is the lung cancer trial published a couple of years ago in New England Journal with spiral CT in a high-risk population. And you can see the, I keep putting this down, but I shouldn't. Where's my nubbin? Here it is. So you can see in this lower graph is the mortality graph. The solid black line, or the darker black line, is the spiral CT group. They had reduced frequency of death from lung cancer compared to the lighter line, which is the chest X-ray control group. But when you look at incidence in these same cohorts, you see the exact opposite. The spiral CT group had significantly higher incidence of lung cancer during this trial, whereas the chest X-ray group had lower incidence of lung cancer. So, so overdiagnosis comes with successful screening as well as unsuccessful screening. So here they have 70-some lives. in their group, but they caused a lot of people a lot of morbidity, and that all needs to be balanced and weighed. So, and then here's another piece of evidence. We did this randomized trial on skin self-exam. It's our Check It Out project. Chucky Check It Out is right there. You see him. He's looking with the mirrors at his skin. You see also at the bottom the website, which has the video we used to incentivize people, to motivate people to do skin self-exams, thorough skin self-exams on a monthly basis. We, in fact, were successful in inducing this group of participants who were people attending primary care practices to do more skin self-exams. We have validation of that. But one other thing which we found is illustrated in this graph, which is that even though at baseline, this is the 6 months before randomization, the blue group, which is the skin self-exam group, versus the purple group, which is the group that got an intervention related to diet, they were similar in terms of the skin surgeries they had performed. But when you look at the first 6 months after they started doing all these skin self-exams, you see that the blue group, who were doing all these skin self-exams, had a lot more skin surgeries. And these were not melanomas. There were no melanomas in that group. But they had, looks like, about double the skin surgeries of the diet group. And then after 6 months, that sort of petered out, presumably because they got used to looking at their skin and weren't alarmed by all the stuff that they saw once they did a thorough job of looking. So this shows that there is certain morbidity associated with and costs associated with screening for melanoma that needs to be taken into account. Of course, one needs to optimize the way people screen for melanoma to minimize the harms and maximize the benefits. The ABCDs, which everyone knows about melanoma. People here know ABCD? Come on, don't be bashful. Raise your hand if you know ABCD. Yeah, okay, people know ABCD. Okay, so it's ABCD, asymmetry, border, color, diameter. That's the warning signs that were published about 30 years ago now to make people aware of melanoma. They're inadequate, particularly for nodular melanoma. So some melanomas follow the ABCDs, others don't. And so we need to do a better job. We generally talk about newer changing lesions now. But we have to focus on better training for the screeners, both primary care as well as patients doing their own screening. We want to prevent referrals for benign things like seborrheic keratoses and benign nevi, because that just causes expense and morbidity without saving any lives. We want to make the training, of course, readily available. And to do this, we developed a curriculum called Informed. A bunch of us, with a lot of input from primary care. You can see that you can see the Informed. It's on the web. This is how you get there. The URL is skinsite.com. You go to the For Professionals tab, and you'll see Informed right there. You can click on them and go through. It takes about an hour, hour and a half to go through. I don't know if you have any updated estimates of how long your people took? An hour. An hour, okay. And gotten a lot of good feedback about that. People like it. It's being implemented now for many primary care docs in Western Pennsylvania in the UPMC related primary care practices. And so this is something I think, and things like it, that will be helpful. This is just some screenshots from the Informed. It's completely web-based. It has these carousels of lesions that you could look at and blow up and see in detail, and you could get some instruction on dermoscopy, etc. We did some testing of the informed. We found sustained improvement in skills of primary care docs who, particularly in primary care docs in their diagnosis of benign skin lesions such as seborrheic dermatitis, seborrheic keratosis rather. And this is really important because if you have some overdiagnosis of melanoma with your screening, which is to be expected, it's nice to have something compensatory like less misdiagnosis of seborrheic keratoses as melanoma, which can compensate for it and therefore make the benefit-risk balance look better for the screening. What we found in at least one HMO setting where we tested it is that it reduced new visits to dermatologists without reducing skin biopsies or diagnoses of skin cancer. So it was eliminating a lot of these benign reasons for referring to dermatology, which is a good thing. So we got to move forward. The way forward is to further demonstrate that screening for melanoma saves lives, and that it can be done in a manner where the benefits far outweigh the risks. I think, as I've said before, and I'll say it again, I think if we get the hard scientific data as best we can, as many as we can, that will eventually convince the powers that be to make this a national program instead of just something that we talk about in PSAs from time to time. So thank you for your attention, and I'll take any questions either now or later.